Welcome. My name is Dr. Paul Bennett, and I'm going to try to present some of the um, guidance on how to do an advanced care planning with a patient and all of the various items that need to be included, and encouraging everyone that this is something we all ought to be doing with our patients. What is it? It's an organized process of communication to help individuals understand what their goals are, what they want for their future health care, and always in the context of what their values are and what their beliefs are. It's a time to sit and reflect. What do you want done? Have you thought about this? Um, oh, what would change your, do you have any beliefs about this? Any worries, any spiritual worries or things along these lines that are going to keep you from planning for what you want done in case you can't make decisions for yourself? Um, we try to make sure that we understand what the future situations and decisions are going to be needed in a particular person's healthcare setting, and that's going to be different for every patient. Um, and then you discuss, after you've reflected on these things, okay, what do we need to do to carry out a plan? Okay. Uh, Next slide. Um, Basically, you want to sit down, take time to listen. Ideally, you can ask them, what's your story about your end of life care? Or if you're involved in an accident, or if you are suddenly die. What is your story about what you would like to happen in those times? Um, and then you focus on goals, on what we can do. Um, we want to address any fears that come up when we talk about this. There might be some misunderstandings of what's going on or what my health status is, or, oh, I didn't realize that. This is the time to get those things all squared away so that everybody understands what the health situation is and fill in any gaps in knowledge that the patient demonstrates or that the surrogate demonstrates. I mean, you want to have ideally, when you do these advanced care planning, it helps to have the healthcare agent or the surrogate or the proxy available so that you can go through these together, and then there's less chance for not understanding exactly what's going on. The types of advanced directives, there are oral ones. I mean, they are probably the weakest. Well, he told me he never wanted this done. Best is written, formal, signed, dated, witnessed. That meets the state requirements, statutory requirements for an advanced directive. If you have a formal, signed, dated, and witnessed advanced directive, then the state has to follow it in the care of the patient. Informal, things like personal letters stating what they wanted done in certain cases, but that's less valuable than the formal. Next slide. Okay, so how do we make it successful? Basically, in the discussion, the patient, future options have to be understood by the patient. Patient has to know, what options do I have? And the options that are available, you consider in light of the patient's values and what their goals are, what they see as their life, and how they want their life to go. Choices are discussed, and then you together formulate a plan, agree on a plan, and then you follow through on the plan. Surrogates and loved ones that are going to accept that if they do follow this plan, they're doing what the patient wants, and it's actually a loving act. Advanced care planning can include who would make decisions, being very clear to clarify what the authority the surrogate has, how far we want the surrogate to go, the patient wants the surrogate to go, how decisions are to be made, and why. It's always good to say why you want decisions made that way. And you want to clearly state when medical treatment should be continued or discontinued or forgotten altogether. Um, Basically, the concept of what it would mean to live well, what it would mean to live your life and end your life as you wished. Next. And there's some barriers to advanced care planning. We all want to avoid, nobody likes to talk about these subjects. We want to avoid the subject. Um, the provider himself or herself might feel a lack of professional skill, training, and confidence. But this is something, as a primary care physician, we do this all the time. And we are the best persons to sit with the patient and take the time, whatever time it does take, to accomplish this. There used to be a lack of reimbursement. Now it's actually adequately reimbursed. Um, so this is something that can be done, and it's possible. Next slide. So basically, once again, sit down, determine the patient's goals, what both their medical goals and their non-medical goals, and then review with the patient the various benefits and burdens for any particular option that the patient has so that they feel comfortable with their decisions. Just some clarification, competent adults have the right to refuse medical and surgical treatment at any time. And if they have done advanced care planning and have a signed formal written plan, even if they lose that capacity, if they become incapable in the future, the right continues. They stated when they were capable what they wanted done, and the state needs to follow through on that. Okay? And the hospital care. And people get confused on the difference between competence and capacity. Competence is a legal definition, and basically, in order to be declared incompetent, that's something that a court does. That's not what we're talking about here. What we're talking about is capacity. It's a clinical term recognized by the law. The ability of a patient to make informed decisions as determined by the clinical assessment. That's how we define capacity. And the way you do that is there's 4 things that are required. The ability to communicate a decision, the ability to understand that one has a choice to make. There's something that needs to be decided here. The ability to understand information presented to them, and then the ability to weigh the benefits, burdens of a choice in accordance with their own values. A person's capable should be allowed to make his or her own decisions and can participate in formulating an advanced care plan. Advanced care plan, though, is relevant only when in the future the patient has become incapable. Another way of stating it is, does the patient understand that the advance directive is about future choices? That the advance directive will only be used when the person has lost the capacity to make decisions. And the advance directive includes a selection of an agent or a proxy or a surrogate who will make decisions for me, and any specific medical preferences that I have are stated in the advance directive also. And the most important thing is changes can be made anytime. So anytime in the future, the person, the choices can be changed to the new preferences. Trinity has put together a advanced care guideline of sorts that talks about the various tiers, excuse me, of for urgency with completing a advanced care plan. And we have people who are in the 50 to 65-year-old age which have a serious illness. Okay, those people should create a power of attorney for healthcare. That's what that POAHC, and consider when a serious permanent injury in the future would change things. Tier 2 are people with progressive, life-limiting illnesses, long-term illnesses that are going to eventually have a bad outcome. And Tier 3 are those type of people who have nothing specific going on, but their overall health is such that you would not be surprised if in the next 12 months they weren't alive anymore. So these are the kind of people they stress are important to get the advanced care planning procedure started. I think also there's a fourth category, and the fourth category is everybody else. Any adult should think about these kind of situations. What would I want done if I suddenly were in a car wreck today and couldn't make decisions for myself? Who would I want to make those decisions for me? And there's nothing wrong with having those things written down and discussing it with who you'd want to make the decisions with, so that everybody is very clear on what you want, your wants are and your desires. And then we have some further resources that are available. And a lot of these are really very nice, very, very helpful as far as getting patients to discuss and think about these issues, which is sometimes the hardest part. But it does help to have these guides work well. And then below we see for professionals, there are some other guides that will help with your planning of how am I going to approach this? How do I sit down and step by step go through this with my patient? This is a doable thing. This is something that you can do. We all were trained to do this. We all feel uncomfortable doing it, but the worst comfortability and the most uncomfortable situation is if you don't do it, and then the patient is in a significant problem, and you don't know what the patient wants. And so that's probably the worst situation to be in as a primary care physician. Questions? We have our information below and contact information. And if you have any questions on these issues, please feel free to contact us. Thank you.